Today we bring you the version 3 of ESH-ISH Bulletin, straight from the European Society of Hypertension's meeting, the exciting clinical science and novel therapies presented today. Today's day began with an interesting presentation on a topic of vascular aging. We know that today we talk about vascular age, and we also talk about chronological age. Chronological age means our actual age, while vascular age is estimated by looking at the stiffness of our blood vessels by a combination of pulse wave velocity. Faster the velocity, harder the artery, and of course the burden of risk factors. Now this study comes from Paris, France. Very interestingly, they looked into the vascular age. All they did was superimpose chronological age on vascular age, as you see there in the graph on the right, the pink and the gray overlapping. They wanted to tweeze out two extremes of this entire category. One labeled as EVA, where the vascular age was far more than the chronological age. So biologically, they were very aged. In contrast, so they are by high vascular age. In contrast, they had the supernova group, which had a low vascular age. So their vascular age was much less than the chronological age. And they tried to compare these two extremes, EVA with a high vascular age and the supernova with a low vascular age. In this interesting comparison, right there in the center is a normal vascular age category. On the left, we have EVA, the high vascular age category, and the left, the low vascular age. Look at the data. In the EVA group, the average chronological age, their actual age, was 64, while their vascular age was 72, an extra 7 years old. In contrast, the supernova group, their average age was 79, which means they were older than the EVA group. But biologically, vascular aging was only 70, which means they were 9 years younger than what their actual age was. And we compare them, we see that obviously EVA group with a higher vascular aging had a higher BMI, more smoking, more hypertension, more diabetes. But in the long run, was there difference? Now this is the 10-year follow-up of EVA with a high vascular age and supernova with a lower vascular age. And we see that EVA with a higher vascular age at the end of 9 years had a significantly higher event rate compared to supernova down there in green, which had a lower vascular age and a lower cardiovascular event rate. So in conclusion, in this data set, they said that there's a novel definition of vascular age. They combine vascular stiffness by estimating pulse wave velocity, coupled with the burden of risk factors. And we see that there is a group called supernova, which patients have vascular age far lesser than their actual chronological age, and their event rates are almost half those with normal vascular aging. So there is a group which does extremely well, those who have got pulse wave velocity, which is favorable, and lack of burden of risk factors. The second interesting paper presented today looks at antihypertensive drug therapy and its effect. The point is, this is a huge meta-analysis of 350,000 patient data and 51 large-scale trials. It was done from the University of Oxford. If we look into the data, they first looked at trials which looked at blood pressure lowering intensity trial. So one arm went on intense blood pressure lowering, the other was less intense. And on top we see systolic blood pressure, the lower graph is diastolic blood pressure. We see that in systolic blood pressure on average, there was 11 millimeters blood pressure drop, the red line, compared to the black line. In contrast, when we look at trials in this meta-analysis where there was comparison between placebo and blood pressure drugs, we see that the drop is much lesser than the intensive trials, but there was still a blood pressure reduction. And the third group is where drug classes were compared. And surprisingly, we see that when drug classes were compared, there's no difference between the trial, both the drugs whatever be the systolic or the diastolic blood pressure is. What does it mean? This means that drug therapy, choosing a drug, is far less important than targeting a blood pressure goal. Point number one. Point number two, we see that over time, there's a progressive decline in the effectiveness of the blood pressure drug. In every trial, as time passes, blood pressure tends to slowly go up. Okay, so in conclusion, the meta-analysis said three important points. One, intensive blood pressure trials had the maximum blood pressure lowering effect. Two, effect of blood pressure lowering attenuated over time in most trials. And third, perhaps most interesting, is that difference of drug classes made the least difference. But imagine that it is a comparison between drug classes, fighting between each classes is what takes most of our time in academics, which is the least important. So it's important to lower blood pressure rather than looking at which drug is lowering the blood pressure. The third interesting trial is on renal artery stenosis, where renal Doppler was tried as a measure to look into the diagnosis of renal artery stenosis. We all know that the standard investigation in renal artery stenosis is the Duplex Doppler, where we look at renal resistive index. Renal resistive index, or RRI, is defined as the peak systolic velocity minus the peak diastolic and diastolic velocity divided by the peak systolic velocity. And we can measure it in the renal artery, 0.65, or renal segmental artery, 0.60, or renal atrial artery, RI, of 0.55. Now, if we look into the normals, so this data set indicated that the normal values, they suggested the renal resistive index need to be between 0.5 and 0.8, and not what was thought to be as 0.70, because it can go as low as 0.5. Now, if you want to diagnose with confidence renal artery stenosis, you need to look at direct signs, which are focal color aliasing, color bruit, turbulence, and a peak systolic velocity of more than 180 seconds. And of course, renal artery aortic ratio of more than 3.5. The indirect signs also need to be considered, which are the acceleration time of more than 0.07 seconds, the acceleration index, and of course, the renal resistive index, difference between right and left. So these need to be considered to make a diagnosis of renal artery stenosis. So in summary, they concluded in this trial that renal ultrasound is useful for screening renal artery stenosis. We all know that, and we agree to that. Important point is, it is good to detect a significant stenosis of more than 80%. Mild stenosis may be missed out by renal Doppler. But most important take-home message is that ultrasound Doppler, all these criteria, they don't differentiate between the etiologies. They don't differentiate between atherosclerotic from fibrodysplasia stenosis of renal artery pathology. So pathological differentiation is not done by ultrasound, but we can pick out those with severe stenosis. The next interesting trial study presented looks into the connection between atrial arrhythmias and high blood pressure. We know that hypertension creates a background for atrial arrhythmias, particularly atrial fibrillation. Now, of course, we know that there is a connection whereby left ventricular hypertrophy because of hypertension can indirectly result in left atrial enlargement because of the increased left ventricular and diastolic pressure. And that left atrial enlargement forms a background or substrate for atrial fibrillation. That is point number one. The second thing is humoral connection between renal artery, between renin-angiotensin system and atrial fibrillation. We know that hypertension accentuates renin-angiotensin axis. In fact, large number of hypertensives have an upgraded renin-angiotensin system. And that upgraded renin-angiotensin system might, by a lot of mechanisms, create atrial fibrillation. Now, if that is so, if we believe that, can renin-angiotensin inhibitors, ACE inhibitors or ARB, prevent development of atrial fibrillation? So if we look into the data available, prevention of atrial fibrillation by renin-angiotensin inhibitors, we see that those hypertensive trials, all those hypertensive trials, did show that yes, there's a benefit. Look at that. The diamond is on the left of the straight line, meaning that there's a benefit in prevention of emergence of atrial fibrillation. Not just by directly remodeling the atria, but targeting the renin-angiotensin system. Of course, renin-angiotensin system inhibitors are beneficial in post-MI in reducing AF, in heart failure, no doubt in reducing AF, but there's a gradient. So, heart failure, yes. Post-MI, yes. But as you see the diamond, a bit of it crosses the straight line. And of course, in hypertension, yes, but the benefit is lesser. So in hypertension, post-MI, and in heart failure, renin-angiotensin inhibitors prevent emergence of atrial fibrillation. The next trial is extremely novel. Baroreflex activation therapy in resistant hypertension. We know that the baroreflex in humans start from carotid sinus. And that is a fast response reflex, which means it quickly resets the blood pressure level. If there is increased baroreflex activity, the central nervous system quickly reduces blood pressure. So can we alter the carotid sinus baroreflex activation, modulate it to reduce high blood pressure, especially resistant hypertension? So in this novel idea, this extremely novel idea, was to place a unique device, a stent-like device in the carotid sinus. And that device alters the shape of the carotid artery from spherical to something like the square shape that you see in the screen. And as it does that, there is increased baroreflex activity from the carotid sinus, and that reduces blood pressure. So there's an emerging science, not yet approved. But if this emerges true, this is good for which patients? This is for early hypertensions? No. But yes, for resistant hypertensives. With hypertensives with multiple comorbidities and complications like obesity, heart failure, and perhaps maybe even prevention of preeclampsia, because we avoid giving a drug in pregnancy. Now, so the long-term effects is not yet known. But the point is, baroreceptor activation therapy lowers blood pressure. And it tends to lower blood pressure in about 50% of those treatment-resistant hypertensives to a level of about less than 140, which is good news. And of course, our impression is that a therapy involving carotid sinus might create orthostatic hypertension, and this therapy doesn't. So BAT therapy does not impair orthostatic regulation of blood pressure. And of course, even an unilateral stimulation is enough. You don't need to put this device on both the carotid sinus. One carotid sinus is enough. And that is a summary of the new emerging device of baroreceptor activation therapy. Lastly, there was a very interesting paper which also has practical implications on central antihypertensive drugs. We know that with the emergence of ACE inhibitors, ARB, calcium antagonists, diuretics, and beta blockers, the centrally acting antihypertensives have gone to the background. For example, we now select centrally active antihypertensives only when combination of RAS inhibitors, calcium antagonists, diuretics, and even beta blockers, and perhaps spironolactone has failed. Now, we know that is why over time we see that centrally acting drugs till about 1990, like clonidine and methyl-dopa, which was so popular till about 1980s, gradually fell into disrepute and their prescriptions dropped because of newer drugs coming in. But then once we got newer drugs like moxonidine, again there was a trend for increased prescription because moxonidine is well tolerated and centrally acting. People started using it in the background of resistant hypertension. But today we are seeing a new era where we are talking about brain aminopeptidase inhibitors. And these newer agents are far more safer, and they are likely to come up in a big way. So brain aminopeptidase A inhibitors, or called BAPAIs, are the new centrally acting antihypertensives, which are the drugs of the future. And if they prove to be safe and effective, they might come into the mainstream, not just in resistant hypertension, but in treatment of the usual essential hypertension. So with that, we end up today's presentation. If you're the kind who hate virtual meetings, if you're the kind who are bored of virtual meetings, and if you thought that this presentation today was engaging and interesting, then stay tuned to ESH-ISH Bulletin. We will be back tomorrow with more highlights. Thank you.